Dr. Mercado. I think we're ready to start.
All right, sounds good. So I'll keep the video on and you'll tell me when I start the slide, right?
Sounds good.
Okay.
Yes. So I'm just going to do a quick introduction.
Okay.
Assalamualaikum everyone. Welcome back to our When to Worry, or I guess When Not to Worry webinar, where the MAPS MCRC Community Clinic is partnering with Muslim health professionals to bring about a set of talks by local physicians about important healthcare topics. So last week we had a session on when to worry about chest pain with Dr. Hamira Ali, and today we're really lucky to have Dr. Marie Mercado from Overlake and talk about diabetes care. Dr. Mercado is an endocrinologist, and she is a physician, or she's a volunteer physician with the MAPS MCRC clinic, and she's available to see patients every Monday virtually through our telehealth platform. So Dr. Mercado, I'm going to share the presentation, or if you'd like to say anything to introduce yourself quickly, that would be great. Otherwise, I can get right into the presentation.
All right, great. Thanks, Nihat. Good evening, everyone. Thank you for having me. And I'm an endocrinologist at Overlake Hospital. There's two of us in the clinic, myself and Dr. Nadia Hamid. So if you guys need any help, we are there. So
thank you so much, Dr. Mercado, for being here. I'm gonna share my screen now.
All right. Then, and I'll stop the video. Started. Okay, great.
That's good. So today's topic, as we spoke about, is diabetes care. Dr. Mercado, off to you.
All right, guys. So I just would like to talk to you about what we always tell or talk to our patients when they first come to the clinic. What are the things to watch out for? Questions to ask your doctor, especially with regards to your diabetes. So the first slide. Okay, so the hemoglobin A1C is I hope everybody's familiar with that. Hemoglobin A1C means that this is the 3-month average of your glycemic or your glucose control. And the reason why it's called hemoglobin A1C is because it basically measures the amount of sugar attached to your hemoglobin molecule. And our bone marrow replenishes our red blood cells every 3 months. So we get a hemoglobin A1C essentially every 3 months if we are making some adjustments, and maybe every 6 months if somebody is stable. So as you can see here, I've actually given you A1C levels with the approximate average blood sugars. And this is important because sometimes a patient will come to the office with a hemoglobin A1C of 12, and they come to us and they don't have any blood sugar readings. They didn't bring their meter or logbook. And then when I ask them what their blood sugars are, you know, they say, oh, my blood sugar in the morning is 120 and 150. So if you see that, you know, if they have a hemoglobin A1C of 12 and they say that their average blood sugar is 120 and 150s, that does not make any sense. So either there's maybe they're not really checking their blood sugar and they're just making up a number, or maybe the hemoglobin A1C is not an accurate measure of your diabetes control. But I think this is always the first thing that we need to know. So hemoglobin A1C, or we call it A1C for short, we do it every 3 months. So the goal by the American Diabetes Association is we want it less than 7%. That's in general. If let's say you have an older person who has maybe less than 10 years of life expectancy with really a lot of comorbid conditions like heart disease or malignancy, then we don't need to get a hemoglobin A1C of less than 7. In that situation, we want the A1C below 8. But in general, for an average, you know, person with really no significant comorbid conditions, the American Diabetes Association recommends an A1C of 7. So it's good to just know what the corresponding average blood sugar is based on your hemoglobin A1C. Next slide. So what are your goal blood sugar levels? First of all, please remember that when you come to your doctor or to your primary care or your diabetes doctor, always please bring your blood sugar readings and your logbook. In our office, we have the capability of downloading your meter or your glucose meter, provided the time and date in your meter are set up correctly. But in general, the blood sugar goals are before eating is 80 to 130, and 2 hours after a meal, less than 180. And so one might ask, how often should we check our blood sugars? And oftentimes when they come to us, they mostly just check their blood sugars in the morning, and they don't check their blood sugars in the middle of the day or in the evening. So the way I handle this when a patient comes to me in the office, if they're on oral agents, I have them check their blood sugars first thing in the morning when they wake up. We call that fasting. And so ideally, we like to see a blood sugar of 80 to 130. But sometimes I do want them to check it 2 hours after their largest meal. And we want that less than 180 because the reason why your blood sugars in the morning can fluctuate also depends on what your blood sugars are 2 hours after, say, dinner. So for example, a patient will come to me and they will say, how come my blood sugars in the morning can be 80 one day, but then the next day it'll be 150? So my answer there is it's probably because it depends on how big your dinner was the night before. So let's say it was a Friday night and it's a pizza night with your family and you had an extra piece of pizza. And so your blood sugar when you went to bed was above 180. And in diabetes, our liver likes to kick sugar out overnight. And that's why our blood sugars are higher in the morning. So when you have a larger meal at night, you go to bed with a higher blood sugar and you wake up with a higher blood sugar. At the same token, if let's say you're on a diet or you walked after dinner, you're going to bed with a lower blood sugar, then you'll wake up with a decent blood sugar in the morning. So these are just important numbers to remember that ideally it's 80 to 130 before you eat and 2 hours after is less than 180. So that is for people with on oral medications. But if you're on insulin, especially if you are on 2 to 3 shots of insulin a day, we really need more frequent blood sugar readings. And we call that intensive insulin management because the amount of insulin that you give at breakfast will lower your blood sugar at lunch. The lunch insulin will lower your blood sugar at dinner. Dinner insulin will lower your blood sugars at bedtime. And so it's important to check your sugars more often. I also ask my patients sometimes, you can check your sugar before you go for a walk and then check it after you go for a walk and see how much your blood sugar drops. That way, it will give you motivation. So for example, I'm going to check my blood sugar before I walk after dinner. It's 180. And then half an hour later, I checked it and it went down to 150. So therefore, it will give you an idea that I need to walk, so my blood sugars will go down. There are, other ways to check the blood sugars. We have continuous glucose monitors now. So that's actually what we've been doing a lot of. Unfortunately, not a lot of insurance covers that. Medicare will only pay for that if you are on 3 injections or you are on 3 injections of insulin a day. If you are just on oral medications, unfortunately, Medicare will not cover that. If you have private or commercial insurance, it depends. It's maybe partially covered, but it will cost $70 or $30 a month. But a continuous glucose monitor, there's 2 kinds. We have the Freestyle Libre, which is what we call intermittent glucose monitoring. And then we have the Dexcom, which is a continuous glucose monitoring. The difference is that the Freestyle Libre is it's intermittent, so you really have to continue to scan, meaning the reader, you need to put it close to the sensor in order to get a data, whereas the Dexcom is continuous. But we can address that later if there are questions about that. So next slide. Next is blood pressure. So hopefully some of you guys have a blood pressure machine at home. I think it's a good investment to have one of those automated machines. But ideally, every visit, your doctor needs to check your blood pressure. So remember, when your doctor checks your blood sugar, you have to not be talking. Make sure you're sitting upright, both of your feet are on the floor, and they have to have your hands or your arms at heart level. The American Diabetes Association recommends a blood pressure of 140 over 90, less than 140 over 90. But if you are an individual with diabetes and you already have a history of heart disease, or you already had a heart attack, or you had kidney disease or renal insufficiency, then we want a lower blood pressure if possible, less than 130/80. It's important to also bring your blood pressure medications or know the dosages, so if your doctor asks you, don't just say it's a white pill. Always be aware or know the names and dosages of your medications, because we always want to review what you're taking at home versus what we have on record. All right, next page. Cholesterol. So this one, we do this every year, at least as part of your physical, or if we are starting you on cholesterol medication, we do it 12 weeks from the start of a medication. And the way I think about this is we don't look at the total cholesterol, but always look at the fractions. So we've got the HDL, and the way to think about this is H for healthy. And so there are different goals, but in general, I say you want the healthy cholesterol to be high, and you want it at least above 45. LDL is your lousy or your bad cholesterol. So we want this at least below 100. Now, if you are an individual with already have a history of heart disease or had a heart attack or had bypass surgery or have other comorbid conditions, your cardiologist will set a lower goal, sometimes less than 70. The triglycerides, this is why your cholesterol has to be drawn fasting. So if you had coffee the day before and you check your cholesterol, your triglycerides will be high. So it's important that you don't eat for 10 hours before you get your cholesterol checked. And ideally, we say a triglyceride of less than 130. So, and here's where I have a lot of discussions with patients, is because there are some patients that don't really want to be on cholesterol medications, or as we call it, the statin. So this is the simvastatin, the atorvastatin. There are some, maybe things on Facebook that are not correctly reported, saying that it will cause dementia and all of that. But the American Diabetes Association really recommends the use of statins for most adults, regardless of cholesterol levels. And why is that? Because diabetes in and of itself is already a risk factor for heart disease. So meaning if you are a diabetic, you are already 4 times at increased risk of having heart disease just by being a diabetic alone. It doesn't matter what your cholesterol levels are. So that's why the American Diabetes Association recommends statins. So the dose depends on, again, whether you're at high risk or you're at low risk, but it is recommended, and that's something that should be discussed with your provider, and at least checked once a year, or like I said, 12 weeks from the start of a medication. Next slide. Now, this one is important too. So kidneys. So this is a urine test. So this is not just a regular urine analysis. This is not to look for a urinary tract infection. But this is a urine test that's randomly obtained. It's best done in the morning. So meaning it should ideally be your first or your second void of the day. But once a year we do this, or if it's abnormal, we do it again on your follow-up visit in 3 or 6 months. And this urine test is known as the albumin creatinine ratio. So what this basically measures is the amount of proteins that your kidneys are filtering. So meaning if your kidneys are affected by diabetes, then the proteins that passes through your kidneys will therefore not filtered by the kidney. And instead of those proteins being reabsorbed back into the circulation, your urine is spilling it out into the urine. And so we don't want to see any proteins in the urine. The goal is it has to be less than 30 milligrams per gram of urine creatinine. So a lot of times your doctor will say, oh, your diabetes already affected your kidney. So this potentially could be what they're saying, is because the filtering capacity of your kidney is no longer that good, because now you are spilling proteins into the urine. This value can be as high as in the thousands. And that's when these are people that could potentially be at risk for dialysis. Most important, the proteins in the urine correlates with your diabetes control and your blood pressure. So for example, a new patient comes to me, their A1C is 12, we check a urine microalbumin and it's 300. Most of the time, if they don't have any other issues, if we get their diabetes under control and we repeat the urine albumin to creatinine ratio, it becomes better. It goes down to 30. The urine albumin creatinine ratio is also affected by exercise and by your hydration status. So getting a first or a second morning void is important. So we do this at least once a year. It can be up to every 6 months or sometimes 3 months if medications are being adjusted. Next slide. Foot exam. So this is important. Once a year, we would like to look at your feet. My patients will ask me when I say I need to do a foot exam, they'll say, shall I take the other sock off too? Yes, I need both of your feet. I need to look at both of them, not just your one sock. So it's important that you look at your feet every night. So I always say, wash your feet at night, inspect it every night, put lotion on the heels, not in between the toes. So inspect for cuts or blisters, any swelling, dry skin, or calluses. I've seen it wherein a patient will notice a blister one night and then the next night it already progressed to a big ulcer. So it's really important that you check your feet every night, especially if you do not have any loss of if you have any loss of sensation. So once a year is recommended, but if you notice sores on your feet, if you notice any change in the shape of your feet, or if you feel like you have like a weird and unusual sensation, let your doctors know so they can examine your feet, even though they just checked it 3 months prior. Please don't go barefoot at home. If possible, wear shoes and socks that fit well. Next slide. So dental exam. I think this is oftentimes what we forget. At least I'm kind of guilty of that, because by the time you get through the rest of the checklist, this is something that I forget. But it's important to note that people with diabetes are prone to gum disease, so periodontal disease. Why? Because if you have high blood sugars, your mouth is always going to be dry, and then that's when dry mouth will cause inflammation and and infections. And so ideally, you want to see your dentist twice a year for cleanings, to check for the health of your teeth, and most importantly, of your gums. And sometimes one day I got a referral from a dentist because the patient's gum disease is so bad, and turns out that this patient really has bad diabetes and the A1C was 12. So it was noticed by the dentist because of poor dental health. Next page. Immunizations. So this is something that certainly we work together with the primary care. Flu shot once a year is recommended. The Tdap. So this is every 10 years if you haven't had one. This is to protect for tetanus infections. Pneumonia shot, we need that 1 dose before the age of 65 and 2 more doses after the age of 65. Herpes zoster, if you're past the age of 50, or this is the shingles. And hepatitis B, this is for all adults under age 60. And of course, I didn't write this down, but the new vaccine not requirement, but recommendations now is the COVID-19 vaccination. Next. I think that's the last one, huh? Oh, eye exam, of course. So eye exam, once a year is recommended. If you are newly diagnosed type 2, it's important that you get seen by an eye doctor as soon as you're diagnosed. And then when you come to your doctor, we will need to know when your last eye exam was. And so I just ask that please make note of who your eye doctor is, what their name is, and have your eye doctor send your primary care your eye exam report. I can't tell you how many times patients come to us. I ask them when their last eye exam was, they don't remember, or I ask them the name and they'll say, oh, it's at the corner of 151st and, Bellred Road or something, and they don't even know the name. And that's how we need to know, because if you have retinopathy or your eye doctor found something, then we need to look for other things like kidney disease, because kidney disease and diabetic retinopathy kind of comes hand in hand. So I think this is something that I would really urge you to keep a note of, is who your eye doctor is, have your eye doctor send the report to your primary care, and when your last eye exam was. Next, I think that's the last one. Yeah, I forgot to write down here, I guess, what do we do for diet? We have diabetes education that I refer my patients to. But in general, as far as, low carb, should we do Mediterranean, should we do keto diet? I can tell you that we do not recommend the keto diet just because it's high in cholesterol, but we do recommend a low-ish carbohydrate diet. And I did not write this down, but we recommend a 30 to 45 gram carb per meal, and 15 grams of carbs for a snack. And for exercise, we recommend at least 150 minutes of exercise per week. So I just thought I'd mention that. Okay.
Thank you, Dr. Mercado. That was really, really helpful. So it looks like there are a few questions here. And just as a note to everyone watching, there's a Q&A button here on Zoom, or feel free to post your question in the chat, and we'll try to get to it before the end, before 9:45. So the first question is, this person says that they're using a Libre 2 sensor, and she noticed coffee in the morning makes her blood go over 180. And she's just wondering why caffeine spikes up.
That's a good question. I noticed that too. We don't really have a good explanation, but I do sometimes, if you are on insulin, I do tell my patients, especially if you're a type 1, I say just give 1 unit of insulin whenever you have your coffee. But it really does that. But, in the morning, people usually are insulin resistant, especially after breakfast. I guess it's just really how our physiology is, but that is a good point. We do see that a lot. So hopefully you don't put anything on your coffee, like, those creamers sometimes have hidden sugar in it. But yeah, even black coffee will really cause a spike, and we don't really have a good answer to that. It is just observed. So yeah, that's very, very observant of you. Yes, we do see that.
Thank you. And then this person is just wondering how patients can check their own hemoglobin A1C. Is there a specific machine that they can use?
Well, you can buy a specific hemoglobin A1C machine, but they're not standardized. So I think I would urge you to not buy it, because it's just a waste of money. It's always best to just do it at your doctor's office. So at the doctor's office, we have the one wherein we get it through your veins, and then we have a finger poke. The finger poke is standardized as well, but even that is maybe like 0.2 or 0.1 off compared to what the venous is. So yeah, don't waste your money. Don't I guess if you don't have health insurance, it's better than nothing at all. But yeah.
Okay, thank you. So in about a month, it's going to be Ramadan. And people are going to be fasting from sunrise to sunset.
Yeah.
And so this person's wondering whether it's dangerous to have, or how dangerous it is to have sugar go too low during the day while fasting, or if there are any tips that you have in order to keep blood pressure or blood sugar normal.
So if you are on a diabetic medication, in particular pills like glimepiride or glipizide, or if you're on short-acting insulin like Humalog or Novolog. So in my patients that observe Ramadan, we actually ask them to hold those medications. Metformin is okay to hold, but it really just depends on how what your baseline diabetes control is. But it is obviously dangerous for your blood sugars to go low. So if your blood sugar goes to less than 70 is defined as low blood sugar. Anything less than 40 is severe, or actually 54 is severe low blood sugar. So I think it's really best to talk to your provider which medication should be held. But the biggest culprit are your short-acting insulin. And medications oral like glipizide, glimepiride, glyburide, those, if you are not eating and you're taking them and you're skipping breakfast, will cause low blood sugars.
Thank you, Dr. Mercado.
Yep.
So another question just came in. Is it true when they say that you can stay pre-diabetic for the rest of your life without it turning diabetic because of your body composition? This person's doctor recently told them that their fasting numbers were consistently over 100 despite having a lighter dinner and incorporating more greens into their diet.
Yeah, so my sister, her hemoglobin A1C, so the way you define pre-diabetes is this. It's a fasting glucose between 100 and before you go past 126. So 100 to 126, that's impaired fasting glucose. So that's basically borderline. Or if your hemoglobin A1C is 5.7 and 6.4, because once you're 6.5, you're a diabetic. So yeah, you can be a pre-diabetic, and you can maybe go up and down between 5.7 and 6.4, so long as, so what we do to these people is we measure their A1C maybe every 6 months, or they go to their primary care. But the best way to assess whether you've crossed the threshold, so to speak, is an A1C and the corresponding blood sugar. So if your fasting glucose is above 126 on 2 occasions, that defines diabetes. If your A1C is 6.5 and higher, that defines diabetes. And so if your A1C is 6% to 6.4, your risk of becoming a diabetic increases to 40%. If you're 5.7 and 5.9, your risk of becoming a diabetic is 20%. So the higher you get up to that A1C, your risk of diabetes goes up. So a lot of us are in the pre-diabetes range, and if we just continue, the usual lifestyle, diet, and exercise that you keep hearing from your doctors, you can be a pre-diabetic and not hopefully progress to diabetes.
Thank you. And then the last question is, are there any symptoms to check for if a person hasn't been clinically diagnosed with diabetes, but suspects they may have diabetes? For example, if they have consistent high blood pressure?
The problem with diabetes is the only time that you will have a symptom is when your blood sugars are really, really so bad that you're like peeing all the time, you're thirsty all the time. So that's really when it's too late, like when your A1C is like above 8 or 9. But if your A1C is like a 6 or a 7, most of the time you really won't have any symptoms, maybe a recurrent yeast infection. But I think the best way is to really just go to your doctor for a physical, give them your risk factor, just say diabetes runs in the family, you're gaining weight. Your doctor will at least do a fasting glucose. And so if your fasting glucose is above 126 on 2 occasions, that's diabetes. But by the time you have the typical adage of frequent urination, frequent thirst, and weight loss, that's usually when it's a little too late, when your numbers are really so high. But the early diabetes, it's really hard. Most of the time, there's no symptoms.
Got it. Thank you. It looks like those are all the questions that we have for today. But just as a reminder for everyone watching, Dr. Mercado does have telehealth appointments available through the MAPS MCRC Community Clinic every Monday. And then you can schedule those online at our webpage. Thank you so much, Dr. Mercado, for your time.
Yeah, this was fun. I'll be happy to do this again. Just let me know.
Yeah, Dr. Mercado is also coming back in, I think, 2 weeks to do
osteoporosis. Perfect.
Okay. So we're looking forward to that. Thank you again for your time, Dr. Mercado.
Great. Thank you. Okay. Bye-bye.
Bye.